so excited to have Meghan with us today to dive into the fascinating and essential topic of pain management from a biopsychosocial approach. Welcome, Meghan. We can't wait to hear your insights.
Thank you very much. I'm happy to be here.
So talk to us a little bit about pain physiotherapy. What is it?
Yeah, it's a really good question. Essentially, the simple answer is a pain physiotherapist is a physiotherapist who's undertaken additional study in pain. Obviously, I didn't start out as a pain physiotherapist. I think the intro was not exactly correct there. I started out, as a young physiotherapist, dove straight into private practice. And as you mentioned, it was those hard to treat patients that led me to undertake further study about 10 years ago now. So if I could, I might just start with an understanding of pain, as that really underpins any discussion about how to treat and manage pain. And our understanding of pain is something that's really evolved over hundreds of years. So it was around the 1600s that it was first proposed by René Descartes that pain was carried along within the nervous system. At that time, it was quite a simple proposal that when a painful stimulus touched your body, it would be carried via a nerve to your spinal cord. It would then travel up the spinal cord and be received by your brain. So it was a signal, a one-way signal, if you will, with the brain as a receiver to that information. Now, not much happened for hundreds of years, and then it was about the 1950s or 1960s with the introduction of new technology and the ability to study the nerves and study the synapses, which are the connections between nerves, that we really started to find out that actually it's not a one-way signal. It is modified and influenced at every level in the spinal cord and at the level of the brain, of course. So we now know that pain is something that is created and maintained in the nervous system. It has the capacity to be modified and then influenced by things like brain state, by things like your mood, your sleep. Perhaps the simplest analogy is that pain is like a fire alarm. So like a fire alarm, your pain system is calibrated to alert the body or alert the system of actual or impending danger. So your fire alarm is calibrated to send off a signal when there's smoke or when there's fire. Your nervous system is the same. It's calibrated to let you know when there might be danger to the tissues. But just like a fire alarm, it can have false alarms. It can go off without any stimulus at all. In fact, we know that you can experience pain without any injury. So it's become really complicated.
So is that when it becomes chronic, like chronic pain?
Yeah. So the understanding of chronic pain, if we just looked at the definition to start with. So chronic pain is pain persisting beyond about 3 months. We use that definition as most tissues have healed within a 3-month period, be it bone or muscle or tendon or ligament. Most things have healed. So we now say, well, if things have healed, why do they still hurt? And that's when we start to look to, there's been some changes. There's been some changes in the way that these nerves talk to each other, or there's been some changes in the way that your brain receives and interprets the signals coming from the body. And those changes are really what underpin this persistence of pain. So it's complicated. And, what does it mean to specialise in pain? It means working within a multidisciplinary team because as a physiotherapist, you only know this part and that is your lens and that is your focus. But then you also need an occupational therapist and you also need a psychologist. And obviously the doctors, the pain specialists are incredibly important in that picture.
I can imagine, Meghan, too, sometimes it would be difficult, especially with transient pain. Like, for example, I've got osteoarthritis and so I'll have like a flare-up in like knuckles or something like that, and it could sit there for a couple of months even.
Yeah.
And then it goes again.
Yeah, flare-ups are incredibly...
And then it's somewhere else.
Yeah.
It just changes. Like right now I've got it and never had it before in my knees, but my knees are playing up. It's like it's crazy.
Yeah, and it's incredibly distressing and sometimes we can hunt around for the answers. Why has this flare-up happened now? And we might sort of speak to that a little bit later on, but certainly a large portion of my job is talking about how can we, first of all, avoid a flare-up? What are the contributing factors towards these flare-ups? Even getting people to write them down and work out ways that they might modify what they're doing so that they don't have a flare-up. And then we actually do need a flare-up plan. You know, what do I do when I have a flare-up? And often it's things like, okay, it's okay to step back and maybe do 25% less. It's okay to have analgesia if you need it. And it's okay to reshuffle your what you've asked of yourself for that week in order to allow things to settle down faster.
Yeah.
Yeah.
It's interesting.
And we know as we age, you're more likely to get pain.
Yeah,
right?
yeah, 100% correct. It's a bit of an epidemic. And if we look at the prevalence rates in Australia, it's approximately 1 in 5 Australians over 45 will experience chronic pain. And we're talking about sort of moderate to severe pain when I'm saying chronic pain, not just the sort of mild aches that come and go. But that number swells to about 1 in 4 in our older age group. So over 85, 1 in 4, so approximately 5%. Got to work on my maths there.
Good maths.
Yeah. Will be experiencing chronic pain. So it really is an epidemic.
Yeah.
And to a huge cost to the healthcare system. I think the figures on the ABS were something along the line of $4.6 billion or so. Yeah. So it's a big cost per year. We see pain increase in older age for a number of reasons. Some of those are because pain is associated with other risk factors, and those risk factors, like long-term health conditions, are also seen in older age, like things like your diabetes, stroke, cardiovascular disease, mental health disorders as well. So unfortunately, there's a two-way relationship between one's mental health and chronic pain. It's easy to understand if you're in pain and you're not able to do the things you want to do, that's going to have a negative impact on your health, on your mental health, commonly causing depression or anxiety. But rather unfairly, the presence of those sort of mental health disorders does actually have an impact on your intensity and your experience of pain. So people really do get stuck in a bit of a bind.
So is there anything we can do to prevent like that pain from happening as we age? Obviously,
this is a big question.
It's a big question.
You're right. Exercising, one of the if we look at the most common causes of pain in the elderly or in older adults, it really is arthritis is up there, and musculoskeletal conditions are up there. Osteoarthritis in particular is the biggest proportion that we see. I think there's about 2 million Australians living with osteoarthritis that is, and something like 3.7 million if we look at the bigger umbrella of all different types of arthritis. So huge issue, huge cost. You asked about prevention. Well, some of the big risk factors are actually overweight, obesity. So absolutely, weight loss is probably one of the biggest ones. Unfortunately, another risk factor is being a woman. Can't do much about that. What other risk factors do we have? We've got, obviously diet, sleep, mental health, staying active, all of these things. And all of these things then form part of one's plan to manage or improve pain as well. So
basically looking after yourself and filling that gap always is a good
balancing life. Keeping social connections, if we think about contributors to mental health, it's often isolation. That's another factor faced by a lot of our older clients. So staying socially connected and engaged in the communities could definitely be preventative to the development of pain.
Very interesting, It's all about looking after yourself. Holistically.
It's very interesting, the interplay though, isn't it? Like, arthritis and all the musculoskeletal stuff that goes on, but the role of the nervous system in that. And then when you're looking at things like anxiety, the role of the nervous system in that and the synapses and how all of those things work together. It's interesting though when I hear you talking about from a lifestyle perspective, like having those connected relationships, getting some exercise, doing those things. And, when you really think about it, there are some beautiful ways that we can get together in community, have some exercise, have some social connection, have a laugh, do some things that are good for our bodies, getting out in the sunshine, all in one hit.
Yeah,
I know. It seems so simple, doesn't it? But yet it can be difficult for a lot of people. And I think our communities aren't built, we don't live in Europe. Our communities aren't built that they necessarily support each other. We're spread far and wide. We live in suburbs. We have to drive to visit each other. And we're talking about a population group. Some of them are not driving anymore or they're, so they're very disconnected. So it does become hard to maintain those preventative factors. Yeah.
When we're talking about osteoarthritis, what are some of the myths relating to osteoarthritis that you think's out there?
Yeah. I had a good think about this question and I thought maybe I could best answer it with a bit of story. I'm going to tell you about a patient of mine, Bob. We'll call him Bob. It wasn't his name, but his name Bob. He's 80 years old. He was a widower. And he was referred to see me because of some very severe right shoulder pain. It was an arthritic joint and he was really struggling with it and he wasn't sleeping. The preceding that, Bob had sort of developed a bit of a grumbly joint and it was a bit stiff, but he was still using it and he was relatively okay. And then he mentioned it to his GP. His GP sent him for an X-ray. The X-ray came back and the GP said to him, look, it's bone on bone, you've got arthritis. And then I'm not sure, I don't think he actually received a lot more information at that point. Maybe you can take Panadol Osteo or something along those lines. So Bob goes home and like a lot of people, he's worried. He feels scared and he stops using his shoulder. He stops using that right arm to carry his groceries. He stops using his arm to reach up to the cupboards or to comb his hair. And this is quite a kind of fit, active 80-year-old, still driving, but he became very incapacitated. He wasn't able to sleep and the joint just got more and more painful. So then, and hence he, after about sort of 6 months of just going downhill gradually, he was referred to see me at the pain clinic. So one of the first things we did was sort of examine like what happened in this scenario. And his case is such a typical run of the mill. They go to the doctor, they get an X-ray, and there's this sort of progressive decline after a diagnosis. So if we go back to some of the myths or misconceptions or even missteps in treatment, one of the first ones there really was that, well, the first myth is actually that you need an X-ray to diagnose arthritis. It is a clinical diagnosis. One doesn't need an X-ray. So a clinical exam, looking for things like painful joint margins or stiffness, morning stiffness. Pain is in there, definitely. The shape of the joint, the behaviour of the pain, all of these things will give somebody a pretty good guess or to really give you a definitive diagnosis of arthritis. So there's no need to go for a costly X-ray. Then there was a really big misstep on behalf of the doctor who was overseeing the case in using that terminology that I threw out there, bone on bone. And I'm surprised it still exists out there in the ether.
It sounds horrible.
It sounds horrible. Exactly. It just evokes in you this, this really unease. And it really does underpin this, making patients feel vulnerable. So they no longer trust their joint, bone on bone, that mustn't be safe. And then that sort of feeds into that myth that if I exercise my joint or if I load my joint, it will hasten its decline, and nothing could be further from the truth. And in fact, it is loading a joint that maintains the health of the joint, that maintains the health of the tissues.
So use it or lose it.
Pretty much.
Yeah.
And it really is important that you're exercising it. It's one of the best things we can do for an arthritic joint. There is a strategy to how we exercise it, and that's the sort of nuances of the healthcare provider and the physio in how to exercise in such a way that you don't exacerbate your pain, but you still get the benefits of the exercise therapy on the health of the tissues. But certainly you can see how he'd sort of fallen down, fallen through the cracks almost. So Bob came in to see me, and first of all, we went through all of this information, how it's safe to load, and in fact, your joint will be better for it. Your pain and function should improve if we do this carefully. And I set him homework, things like, let's start using that to carry light objects. Let's start reaching just within your comfort zone, but maybe slightly extending out that comfort zone or that safety net over some weeks. And when he came back to see me for his second appointment, he was 60% better.
Oh,
so he
wow.
was still in pain, sure, but it was back to where it was right at the start. A bit grumbly, on and off, and he was no longer afraid. He was happy with it as it was. He was confident he could cope with it as it was, and that was it. And it can be that simple. It can be more complicated, I admit, but it just illustrates the importance of that early education and that early message and the sort of, as we said, those myths that are circulating that actually you shouldn't exercise, or if you weight bear on your arthritic knee, you're going to make it worse, or don't run on your arthritic knee. These are all terrible myths.
Yeah, wow. Interesting.
So what causes a flare-up? Because obviously there's a big difference between osteoarthritis, for example, and rheumatoid arthritis.
There is,
because, one's an autoimmune disorder and the other one isn't. So how do we explain that to people too?
Some flare-ups are through known causes, and one of the most known causes for osteoarthritis would be a overactivity. So that means undertaking an amount of, let's say it was gardening or going for a walk if we're talking about knees, over and above, like significantly over what you've been doing on average. Generally, when we're talking about exercise, we're trying to get people to stick within a known amount, a sort of baseline quota, and then increase by very small quotas to avoid flare-ups. But occasionally they might go to a wedding and stand up all day, or, there's things arise. So that's the sort of more common feed into a flare-up. Some are a little bit trickier, to do with the disease processes, that they can go through periods of time where they're more active. I can't speak to that, fully not as a rheumatologist, but certainly if you're maintaining healthy lifestyle, if you're sleeping, if you're eating well, if you're out and about, you're doing everything you possibly can. In fact, most people with osteoarthritis actually have quite a stable disease progression. It doesn't progress really rapidly. So those rapid changes in pain that you were describing really are flare-ups in sensitivity of the nervous system, and more or less frequently, it would be because there's been a rapid change in the disease process within the joint. So the other things you look at, why is this nervous system more sensitive? Someone hasn't slept for a few days, or God forbid a loved one's passed away, or, there might be other emotional. There might be some other things going on in this person's life.
So going back to like patients like Bob, how would they see a pain physio? Do they need a referral from a GP, or can they book directly with the clinic?
Yeah,
Was it a mix?
For where I work, it's a specialist clinic, and that you do need a GP to visit there.
Yeah.
There are some great pain-informed physiotherapists in the community, and one doesn't need a GP referral necessarily to find them.
Yeah.
Just a bit of Google searching and, careful reading of people's bios is a good place to start. Yeah.
Yeah, okay.
There is so much information out there. If we look at myjointpain.org.au. So this is an OA support website. So essentially there's tips on managing pain, there's info on OA, how to choose your healthcare provider, how to be your advocate, everything like that. We've got a Joint Action podcast, which is by a prominent rheumatologist. Again, there's a mix of interviews, information, tips and tricks. And the arthritis movement was another one I thought that was a really good resource. That's a collaboration between the two peak arthritis bodies in New South Wales and in Queensland. So
and
again,
of course, when you say OA, we're meaning osteoarthritis.
Oh, sorry. Yes. Yeah. So, actually the quality and amount of free information on osteoarthritis and arthritis in general online is incredible. I would say almost more than other pain conditions, which is reflective of the healthcare cost and
it's very common.
The commonality and the amount of research, and also we're really in this preventative space that actually the more people know about this, we might be able to reduce some of those number figures that we were talking about earlier.
So what about supplements, Megan? Like a lot of people take fish oil and krill oil and all of these kinds of things.
It's a bit of a minefield. I know that there's more research going on, I think, into things like turmeric, and I have to say it's outside of my scope, to be honest. I do feel that sometimes loading up on supplements can just be a big waste of money, and that, in fact, looking for just a healthy, balanced diet as prescribed by your dietitian or GP.
Have some salmon.
Yeah, exactly. Lots of fresh vegetables, fruits.
You should go fishy yourself. There's some exercise
using
for you
joints.
too.
I love it. Yeah.
Gee, I will go with you.
Yeah. I think it's one of those questions about supplements and diet. Look, the more we know about diet, the more we know it does impact. But because every person is unique, every person's gut biome is unique, we can't be saying this is the anti-arthritis diet, because it might be for someone, but it's not going to be for someone else.
Yeah, exactly.
So we can't give
trying what works for you. Isn't
Correct. You know, if you have some food and you feel that continuously or regularly inflames your arthritis, well, stop eating it. Stop eating it. That might be a trigger for you.
And do you work with nutritionists much to perhaps
I have
suggest?
in one of my other roles. I've worked with a dietitian and was absolutely blown away by her work. So I think there could absolutely be a role for a dietitian or a nutritionist in one's healthcare team. Yeah.
And that it depends on what type of pain they are experiencing, of course, as you mentioned before, such a complex and broad, disease. I suppose is this a disease or something? What would you call it?
Arthritis is a disease. Yeah, it's a disease of the joint. So not just the cartilage. I think it's another misconception. It's just a disease of the cartilage, but it's actually a disease involving the cartilage and the bone and the capsule and the ligaments. You know, everything's impacted.
Can you talk a little bit about pain management plans, like what they are, how to get one, who writes them, what's in it?
Well, any well-informed healthcare professional can write a pain management plan. I see some really good ones come from GPs. As we've touched on, pain is incredibly complex. I think the first thing to see is this health professional the right person for me? Are they asking the right questions? You know, they want to be asking you lots of questions about your pain, about your function, about how you're coping, about your beliefs, you know, what's working, what's not working, and then coming up with collaborative goals, you know. And if that sort of process isn't happening, then you may not be getting your best possible care, and you might want to look for somebody else. But as I said, I've seen some brilliant plans come from all walks of allied life, and also even your GPs can be a great source of knowledge and information. As to what it includes, look, the majority really are lifestyle modifications. So as we talked about before, weight loss is incredibly important. So a weight loss plan or a weight management plan would be incredibly important. An exercise plan, graded exercise, and sure, that would probably be under the guidance of a physiotherapist or an appropriately trained exercise physiologist, and sometimes even your PTs. We would obviously want to have some sort of sleep hygiene discussion. You know, how is this person sleeping? Are there any bad habits that have crept in? Are they on their phone in the middle of the night? You know, so developing strategies around that to improve the quality of someone's sleep. We would also be looking at, what haven't I covered? Pacing. Pacing's a really big one, that discussion that we had earlier. You know, how much to do, how hard to push into pain. We do a lot of sort of reflective questioning, you know, how quickly does your pain settle down after the event, to ascertain was that the right amount or not. Essentially, it's it's safe to push into pain, but if you're doing it too regularly, you may actually end up making your nervous system more and more sensitized. So you'll go backwards rather than forwards. So there is a bit of a strategy to that.
Yeah.
And also, how do you understand your own pain tolerance, and when is it actually okay, or when you're pushing a little bit too much?
Yeah. I usually teach that with, I guess, a little bit more questioning. So when you're pushing into pain, is it a pain that you can breathe through, that you can relax into whilst you're experiencing the pain? Or are you starting to kind of show those other signs of distress or stress, like holding your breath or gasping, or your heart's racing, or you're tensing? So we're seeing other signs of stress coming in. I would say that's probably too far up the pain pain cycle, and is more likely to result in rebound pain afterwards. So if you're pushing to a level that you can, still maintain a conversation in and still be calm and relaxed, look, we're probably in a low risk type situation.
Well, Meghan, thank you so much for your time today. It's been so insightful, and I'm sure very, very helpful.
Absolutely. Learned so much.
Many.
Yeah.
Thank you. Thank you for having me.
Thank you. Thanks for tuning in to this episode of Conversations with G&G. We hope today's chat offered some fresh insight and support for your caregiving journey.
If you're looking for more tools, strategies, or just a bit of encouragement, head over to our website. You'll find resources to guide you every step of the way.
Whether you've just started out as a caregiver or you've been caring for a loved one for years, there's something there for you.
Don't forget to subscribe, share this episode with someone who needs it, and join us next month for another real, honest conversation.